Good morning. I'm Dr. Paul Limberg. My colleague Dr. Jeff Alexander. We're here at Mayo Clinic during a screening colonoscopy procedure for Mr. Lee Acey. We're just getting started with the procedure. Colorectal cancer is estimated to occur in about 130,000 individuals in the United States in 2016. Unfortunately, about 49,000 people will die from colorectal cancer this year as well. Screening is highly effective, and colon cancers actually can be prevented. So if you're over age 50 and in otherwise good health, colon cancer screening is probably right for you. Talk with your healthcare provider about which of the different options might be most acceptable. Colonoscopy is one way that we can screen for colorectal cancers and colorectal polyps, which are the precursors to cancers. If we find colorectal polyps during a colonoscopy, typically they can be removed and prevent colon cancer from even forming. The beginning of the experience for Mr. Acey actually started yesterday as he was getting prepared for the colonoscopy. The preparation for the exam is absolutely critical for us to see what we need to see. The colon has to be cleaned out so that Dr. Alexander or another colonoscopist can actually examine the inner lining of the colon called the mucosa and find those things, polyps or other things that may need to be taken care of during the exam. So as I'm just watching the video monitor as we get up to the top part of the colon, it looks like Mr. Acey has been very compliant with his preparation. Everything looks good so far. The first part of the actual colonoscopy procedure, after the patient is comfortable, after Mr. Acey received the medications that are allowing him to be nice and relaxed during this exam, then Dr. Alexander is inserting the colonoscope up to the upper part of the colon, an area called the cecum. Cecum is where the small intestine enters into the colon. Typically that takes several minutes to get up to the cecum, and then the more detailed inspection to look for polyps or anything else that might need attention is performed on the exit of the colonoscope from the colon. Altogether, the procedure typically takes about 20 minutes, so it's a very quick and easy procedure when you're sedated as Lee is, and you have a experienced colonoscopist who has done these procedures many times, such as Dr. Alexander.
One of our Periscope viewers was asking about the potential if you find polyps, and I'm not quite sure I'm communicating their question correctly, but do you actually do a biopsy, or do you actually take action right away if you find a polyp?
We can do either one. So if there's a polyp that looks like it's amenable to removal, we would just go ahead and take the polyp out during the screening colonoscopy procedure. If it's a polyp that looks like it might be in a certain position or of a certain size that it would make it a little more challenging to remove during that first setting, sometimes we would take a biopsy, and then the polyp can be treated at a later date.
Somebody was actually asking here on Periscope, they wanted to know, at what age do you stop screening for?
That's a great question. There are some societies who have suggested that stopping screening at about age 75 may make sense from a cost effectiveness standpoint. Between 75 and 85, there are still benefits from colon cancer screening. I think the general recommendation that I would have is talk to your clinician. If you're in otherwise good health, I wouldn't use the calendar to make the final decision about whether or not you're eligible for colon cancer screening.
Somebody was asking here too, they said that they had a flat polyp. Is that possible?
Flat polyps are possible. Polyps come in many shapes and sizes. Most polyps, or traditionally precancerous polyps, we would tend to think of as looking sort of like mushrooms with a stalk and a head on top of the polyp. Those can typically be removed with a little wire snare or another technique to put around the stalk of the polyp and then just clip it off, if you will. Flatter polyps can be a little bit different treatment procedures. So lifting a flatter polyp up and then kind of cinching it off the top of the mucosa is a way that we can take care of polyps that are of that shape.
Another question is, with products like Cologuard, is it really necessary to do something like this?
So Cologuard is another colon cancer screening option. So Cologuard is the commercial name for a stool DNA test. The test actually checks for cell fragments, DNA, and also for blood in the stool. So Cologuard would be one of those stool-based colon cancer screening options. Colonoscopy is one of the structural colorectal cancer screening exams. Again, it may be that there are reasons to choose one or the other, and patients and their providers should make that decision together.
Someone asks, are flat polyps more prone to cancer?
We're just beginning to understand the natural history of flatter polyps. Under the microscope, they tend to have what we call serrated features. There are some studies that have suggested that those polyps actually may develop more quickly in patients who are predisposed, and they may actually progress more quickly to cancers. So yes, we pay particular attention to flat polyps, and sometimes we set our subsequent screening or surveillance guidelines differently if someone has had flat or serrated polyps.
Another one of our questioners wants to know less frequent scopes with negative results?
Absolutely. So for screening colonoscopy, if the exam is entirely normal, no polyps are found, you can wait even up to 10 years before the next colonoscopy exam. In addition to colon cancer screening, there are some things that people can do to reduce their risk for colon cancers. Knowing about modifiable risk factors is important. The modifiable risk factors that would be most well established would be eating a diet that is high in plant-based compounds or fruits and vegetables, maintaining a healthy body weight, getting plenty of exercise, and avoiding tobacco. Now those sound like things that are good for you in general, and they're good for your colon. They help to reduce colon cancer risk. There are some other risk factors for colon cancer that are not necessarily modifiable, but they help us with our suggestions for when screening should start or how often screening should occur. And those things would include age. So general colon cancer screening should begin at about age 50. African Americans tend to have, based on studies that have been done, colon cancers at a higher rate and a younger age. So colon cancer screening guidelines for African Americans would suggest starting at a slightly younger age. Patients who have inflammatory bowel disease like Crohn's disease or ulcerative colitis often undergo a different colon cancer screening regimen than somebody who doesn't have those conditions. Type 2 diabetes is also a risk factor for colon cancer, and that might go along with some other of the modifiable risk factors like nutrition and body weight and those sorts of things. But for patients who have type 2 diabetes, they may also want to talk with their physicians or clinicians about when to start colon cancer screening.
Somebody asks, how quickly will a change in diet actually have an impact?
I think a change in diet at a subcellular level probably has an impact very shortly after making that positive change. In terms of reducing colon cancer risk, it's a little bit harder to say. Most of the studies have looked out at, say, 3 years or 5 years after an intervention like a change in diet, and that's where we tend to see the real results from healthy diet changes occurring.
And somebody asks, how do you restore the gut flora after something like this? Is that necessary?
Yeah, so the interactions between the gut flora or the microbiome and numerous health conditions, including colon cancer risk, are just emerging. So we don't know for sure exactly what the impact of the bacteria that live in the colon have on colon cancer risk, but there seems to be a connection. So we're doing some research here at Mayo Clinic and in collaboration with other groups to try to understand the role of the fecal flora or the fecal bacteria, the colon bacteria, on health risks.
Lots of great questions coming in here left and right. I'll try to relay them as well as I can here. Is there a greater risk for colon cancer in men or women?
Really, the risk over a lifetime is about the same. Colon cancer affects both men and women. I think there's a myth out there in the past that colon cancer was a man's disease. Depending on age of the individual, the risks might be slightly different, maybe slightly higher for men than in women. But overall, the risk for an individual of colon cancer is about 5% over the course of a lifetime.
Another question that we're receiving is, what about the prelude to this actual procedure? What about if I'm on prescription medicines like blood thinners and other things like that? Should I stop them? What exactly?
Yeah, that's a great question. So again, getting ready for the colonoscopy is probably the most important part of the initial experience. So rather than stopping medications on your own, make sure you talk with your healthcare provider. Talk to the person that prescribed those medications before you stop them, but do it well in advance. I would say, a couple weeks if you can in advance of your colonoscopy, just to make sure that by the time you get to the preparation, everybody knows what medicines are discontinued, what medicines are being continued, so that we can get the best exam.
So give me a ballpark guesstimate. How quickly is Lee going to be able to resume normal activities, a normal schedule?
After a colonoscopy, at our institution, most places, patients are typically watched for about an hour in a recovery area. That allows the sedatives to wear off. After that, patients are generally, wide awake and ready to go. Might feel a little bit tired, still some effects from the sedatives that we use, but otherwise, same day feeling good. And generally, patients take a day off of work. We ask patients to not drive or to make legal decisions for 24 hours after we've used conscious sedation. Those are just for protection of the patient and for anyone else who might be on the road.
I want to ask you about something. I'm not sure how up you would be on this, but one of our Periscope viewers is asking about a Canadian study, a task force study that had some recommendations possibly against doing this sort of procedure.
Yeah, so again, I think that there are some differences of opinion as to how best to screen for colon cancer, colon and rectal cancer. Different expert organizations have come up with different recommendations. So again, I think there are multiple options. I think finding the test that's right for you, that your provider has confidence will be the test that should be used for you, is the right way to go. I know the Canadian medical societies have strongly endorsed some of the stool-based tests, which U.S. societies and many other societies also endorse. Whether there's only one option, we would say, at least in our practice, that there are multiple different options that have been shown to be effective, and it's a decision between the provider and the patient to choose the right one.
Another Periscope viewer wants to know, does colon cancer have a lot of symptoms?
Colon cancers can present with no symptoms. So sometimes during a screening exam even, we can find polyps which tend not to have any symptoms, cancers which may not have any symptoms. So it can be an asymptomatic discovery, which is why screening is so important. Some symptoms that can go along with colon cancer would include blood in the stool. So anyone over age 50 or at any age even that notices red blood in the stool should bring that observation to the attention of their doctor. Sometimes black stools can signify blood that's been in the colon for even longer time, so that would be another way that blood can show up in the stool. Change in bowel habits. If somebody experiences a change in their typical bowel pattern, that would be something else to bring to the attention of your clinician. Change in stool caliber, pencil-thin stools can sometimes go along with rectal cancers or cancers that are down lower in the colon. Just a general sense of fatigue or unintentional weight loss, those might signal health conditions in the colon or elsewhere. Bottom line, common sense goes a long ways. If there's something new or different, make sure you talk with your healthcare provider. This is the upper part of the colon. We look for some specific anatomic landmarks. One of them is the appendiceal orifice, which we'll see here in just a minute. And the other is where the small bowel comes into the large intestine, called the ileocecal valve. So there's the appendiceal orifice. That's the inside of the appendix, the inside of the beginning of the appendix, if you will. And that just allows the person doing the procedure, Dr. Alexander, to know that he has made it to the top of the colon and that we've inspected, or we're at the point where the more detailed inspection can begin once we take a peek in the small intestine, if it's possible to do so. This is that ileocecal valve. And sometimes the scope just pops in, which Dr. Alexander was just able to navigate. So this is the end of the small intestine. We get a little extra look here just to make sure that that looks okay. There can be inflammation or some other conditions that can occur in that part of the colon, so it's important to do that part of the screening exam if it's technically feasible. The colon produces and the small intestine produce some of those liquid secretions, so that material that's coming down is generally there, even when someone has had a very nice colon prep, as Mr. AC spent some time with yesterday and today, making sure that that his colon was clean for inspection.
One of our questioners asks, do you use anything at the end of the scope to pull back the folds?
Jeff, is that part of your typical practice to pull back folds? You can use biopsy tables and some of the instruments that we would pass through the colonoscope. I think most endoscopists would not do that routinely. It's more the position of the camera to get a good look behind the folds. But Jeff, do you have any special techniques that you use?
Sometimes a cap will help you, but we don't use that routinely unless I'm in a small bowel. And there are a couple new techniques coming out, scopes with kind of lights, cameras on the side as well as something with a kind of a reverse camera that kind of looks backwards. So there are areas behind the folds are difficult to see, and I think some technological advances that aren't in the mainstream practice yet may help with seeing behind these folds, as it can be a bit tricky, and things can hide behind folds.
And one of our questioners asks, after you have one and they do take polyps out, how often should you have a recheck afterward?
So the follow-up interval depends on a few different factors. Depends on your personal medical history and your family history. Depends on the number of polyps, the size of polyps, and the microscopic features of those polyps. So depending on all of those factors in combination, the interval could range anywhere from several months if there's a big polyp that had to be removed, up to 5 to 10 years if there's very small, tiny polyps that are few in number.
And one of our other viewers wants to know, what about the yellow spotting that we're actually seeing in some spots in here? Is that a concern? What exactly is that?
Yeah, so that's the residue, colon secretions, and sometimes mixed with the prep. That's absolutely normal. It's hard to get the colon completely clean of any residue, and that's generally easily washable from the surface of the colon lining.
And that is water that you're using here, right? Correct?
Correct.
Yes. Why don't you give me an injection needle and a cold snare?
So Dr. Alexander is using the narrowband imaging to look in higher resolution at the colon mucosa. Just a little bump that's showing up here that looks like it could be a tiny polyp and amenable to removal here with a technique that Dr. Alexander will pass an instrument through the stroke and either biopsy or remove that area.
I think I'm just going to use the X-Acto set.
What's going through your mind, Dr. Alexander, as you do this?
Well, there's a little nub in here. I'm not sure if it's a polyp. We worry about these things called sessile serrated adenomas in the right colon. And I'm just going to take this out.
And those can be those flatter polyps that we talked about a little bit earlier, Dave, these sessile serrated adenomas, the serrated feature under the microscope, the sessile meaning a flatter appearance during the colonoscopy. This one is pretty small, but sometimes that's the way those things show up. So endoscopists typically, if they see something, if they have any questions, they'll go ahead and take a biopsy or remove the area. They can do that safely right during this screening procedure.
But it should be emphasized, this is exactly what we're trying to define, whether it's good, bad, or
that's exactly
or whatever.
Right. So the purpose for doing screening colonoscopies is to characterize what the anatomy looks like, and if there are any of these small changes to the lining of the colon, we go ahead and remove those so that we get a chance to look at them under the microscope.
Well, the more I'm looking at this, Paul, the more I'm not thinking this is anything.
Yeah, and another thing that Dr. Alexander has done here since we started the conversation about this little area that he was giving closer inspection, when you put a little bit more air or inflation into the colon, sometimes those mucosal folds can separate even more. And what looks like a little bump might just be an area that flattens out completely and doesn't require any attention when we're doing the procedure. So I think as you distend the colon a little bit more, that's really the next step prior to deciding whether or not there's any intervention or biopsy or removal that needs to occur.
And after looking at this, I don't think this is anything.
Could you repeat that?
I say after looking at this with better air insufflation, as Paul said, I don't think this is anything.
And that's another common, that's having a skilled endoscopist and being able to find those little things that catch your initial attention, and then doing the right maneuvers from that point forward to determine whether or not it needs to go to a next step is all part of the screening exam. So as we discussed, the more detailed inspection occurs on the way out. And so what Dr. Alexander is doing is just taking a look at all of the different facets of the colon and rectal mucosa, the colon in this instance up until this point. As Dr. Alexander withdraws the scope, he also removes some of the air to make the post-procedure more comfortable for Mr. AC after he's had a chance to look at the area that he's passed through. Lee, you're doing fantastic.
Yeah, give us an update on how Lee is actually doing, and
He looks very relaxed.
relaxed.
Good.
You pretty comfortable, Lee?
I am.
Right leg up. There
If you
you
need more medicine, we can do that.
So changing position can help some of that residue move off of certain areas of the folds. Again, it can help the colon relax or change position slightly. It allows us just to make sure that we're seeing a 360 view of the entire lining of the colon during that careful withdrawal phase inspection.
A question that's come in on Periscope here. They want to know about the video pill and the use of that and how valuable that is.
Yeah, so there's something called capsule endoscopy. Capsules can have one camera. Sometimes they can even have a two-headed camera. And the way that those tests are performed is a patient would be asked to swallow what's called the pill cam, and then as the pill camera tumbles through the small intestine and large intestine, it takes pictures and sends it to a wireless recorder. It can be used for a lot of different conditions. Typically, we would use that to detect any bleeding sources that might be in the intestine somewhere that are harder for us to detect just because of the challenges of reaching a specific part of the small intestine, for example, with a extremely long scope. So pill cams are good for finding bleeding disorders or bleeding lesions. For colon cancer screening, there have been some studies looking at the pill cam, but you still have to take the preparation. Sometimes you even have to take a more aggressive preparation than you would for a colonoscopy, because you don't have the ability, as Dr. Alexander is doing here, to really remove any of that fluid or remove any debris, and the pill cam may not be able to see through that as it tumbles through the colon. Mr. AC looks perfectly comfortable. He's a little bit awake, which is also just fine. The goal of the sedatives is to make the person comfortable doing the exam, not necessarily to make you sleep through the whole thing. So Lee, can you see the screen?
I can see the screen.
Everything looks really good. There's a little bit of liquid in there, a little bit of residue, not too bad. All areas that Dr. Alexander has been able to suction or take care of here to see what's underneath.
And of course, some of our Periscope viewers have been wanting to know, and you sort of answered their question, and that is, you're pretty much out for this procedure. I mean, you're pretty much not awake for this procedure.
That would be the most common experience. So some patients actually will sleep right through it, wake up in the recovery room and say, when are we going to start? And the procedure will already have been completed.
Wow.
Some patients, like Lee, are very comfortable, and maybe towards the end of the exam they start to wake up a little bit. Some patients like to watch the exam on the screen. So again, it's really a little bit person dependent, case by case. We want to give the right amount of sedatives to make the exam comfortable, but not so much that patients have a hard time waking up or feel the side effects of the medications any more than they would otherwise.
And most of the discomfort is on the way in, so because you're doing some pushing and distending the colon, and that can be uncomfortable for the patient. So often, if you come out slowly, the medicine starts to wear off, they're more comfortable and they may wake up some. We can always give them, if he's least bit uncomfortable, we'll give him more. How are we doing there?
I'm doing fine.
Good, okay, all right.
Yeah,
Well, Dr. Limburg, one of our
I think it will, but what's looks like, and I'm glad to hear that it's basically looking good.
Yeah.
And Dr. Lindberg, question from one of our Periscope viewers, and that is, any idea why there seems to be more colon cancer in young people these days?
Yeah, I think that there's more discussion about colon cancer, and so I think that more people are aware of screening after age 50, and sometimes even people talking with their physicians about if they should start screening prior to age 50. So just general awareness about colon cancer and some of the risk factors is a contributor. So prior to age 50, most colon cancers happen at an older age, and the average age is about 73 years. About 5% of colon cancer cases occur in individuals under the age of 50. Some things that can predispose or increase risk in a younger population, I mentioned African Americans tend to have colon cancers at a slightly younger age. Family history of colon cancers, colon polyps, sometimes even other cancers. There are some syndromes that at a genetic level somebody might be predisposed to forming colon cancer or even other types of cancers. So if you have a pattern of cancer in the family, that would be another reason to talk about getting screened earlier or prior to age 50. And then some of those health conditions that I mentioned previously with inflammatory bowel disease, even type 2 diabetes. So as we increase awareness, as we have patients who have more of these medical conditions coupled with a family history that's suggestive of colon cancer and going in and being proactive and getting screened, I think all of that is contributing to more awareness and maybe even a higher percentage of polyps or sometimes cancers in younger patients.
Well, as we wrap up this broadcast, any final thoughts, Dr. Lindberg, Dr. Alexander, about what we've seen here this morning and, essentially takeaways from what folks have seen?
Yeah, so what we've seen this morning is an exam that went extremely well with no findings, no worrisome findings. Again, I think Mr. Acey's experience would be sort of the norm for people who come in asymptomatic for their first screening procedure. Sometimes we find some small polyps. We didn't find any in Lee's procedure. So I think getting colon cancer screening according to the standard guidelines, starting at age 50 without any of the risk factors that you may read about or your doctors would mention, is what everyone should do. We've got about 70% of the population who are adhering to colon cancer screening recommendations. We've got room to move. So the bottom line, the last message that I would pass on is colon cancer screening can be done through multiple different options. Find the one that's right for you, but get a screening exam.
Dr. Lindberg, Dr. Alexander, thank you very much.
Thank you.
And,
My pleasure.
and Dr. Alexander, did you have any final thoughts too, or?
No, I just agree with Paul. 30% of people aren't getting screened, and we need to do that.
All right. Well, thank you both, and thank you for a very successful procedure, and we definitely do thank our Periscope viewers for checking this out.